Hello, everyone, and welcome back to clinmedcompass, your trusted guide through the essentials of clinical medicine. I am Dr. Emorinken, and today we are diving deep into one of the most common and potentially deadly infections in medicine, pneumonia. Whether you are a medical student, a healthcare professional, or just someone passionate about understanding how the body fights infection, this video will give you a complete, structured, and clinically relevant overview of pneumonia, from the definition to diagnosis, management, and prevention. So grab your notes, sit back, and let's begin. So, what is pneumonia? Pneumonia is an infection of the lung parenchyma, that is, the functional tissue of the lungs, including the alveoli. This infection triggers alveolar inflammation and consolidation, meaning the air sacs fill with fluid or pus instead of air. This leads to impaired gas exchange, causing hypoxia and respiratory distress. Historically, it was so deadly that the great physician William Osler famously called it the captain of the men of death. Clinically, we diagnose pneumonia using a triad: fever, respiratory symptoms like cough and shortness of breath, and a new infiltrate on chest X-ray. Keep that triad in mind. It's your diagnostic anchor. Before we go further, let us clarify some commonly confused terms. Bronchitis. Bronchitis affects the bronchi, the larger airways, but spares the alveoli. No consolidation on X-ray. Bronchiolitis. Bronchiolitis involves the bronchioles. It's usually viral and common in young children. Again, the alveoli are spared. Pneumonitis. Pneumonitis refers to the non-infectious inflammation of the alveoli and the lung parenchyma. Think radiation therapy or chemical exposure. Pneumonia, by contrast, is infectious inflammation of the alveoli and the lung parenchyma. This image illustrates a healthy lung compared to the one infected with lobar pneumonia. Now we see the central airway, the trachea, which branches into the bronchi, and subsequent the secondary and the tertiary bronchi, then to the tiny airways, the bronchioles, before leading to the alveoli. This is a section of the alveoli, which are the air sacs where oxygen exchange takes place. However, if there is pneumonia, let's say infection by strep pneumoniae, it causes inflammation of the lung parenchyma as well as the alveoli. The alveoli becomes inflamed and filled with pus or fluid, thereby affecting gaseous exchange. Now, let's talk about numbers, because pneumonia is a global health giant. Globally, there are approximately 450 million cases of pneumonia annually, and tragically, about 4 million deaths. It is the leading cause of infection-related hospitalization and the third leading infectious cause of death worldwide, after only HIV and tuberculosis in some regions. Who is most at risk of pneumonia? Children under 5 years, adults over 65 years, and anyone who is immunocompromised, whether from HIV, chemotherapy, or long-term steroids. So how do healthy lungs normally avoid pneumonia? Our respiratory tract has 3 layers of defense. The first, the mechanical barriers. The nasal hairs filter particles. The epiglottis prevents aspiration, and the cough reflex expels invaders. Then we have the mucociliary clearance. These are tiny cilia that move mucus and trap pathogens up and out of the lungs. Then the third is the immunological defenses, like the alveolar macrophages. They act as first responders, while the secretory IgA and a humoral and the cell-mediated immunity provides an additional backup. But when these are disrupted, either by smoking, viral infections, or by aspiration, the door becomes open for infection. Let us talk about the classification of pneumonia. We'll start with the classification based on the causative pathogen. We have the bacterial pneumonia, which could be atypical or typical. Atypical bacteria include Streptococcus pneumoniae. This is the commonest cause of community-acquired pneumonia. Other typical bacteria include Haemophilus influenza, Staphylococcus aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa. Then the atypical bacteria, they include Mycoplasma pneumoniae, Legionella pneumophilia, Chlamydophila pneumoniae, Coxiella burnetii. These ones are atypical because they usually don't stain well on gram stain. Viruses are also major players, especially influenza virus, respiratory syncytial virus, adenoviruses, parainfluenza, and the coronavirus. Beyond bacteria and viruses, we also have the fungal pneumonia, especially in the immunocompromised patients. Pneumocystis jirovecii in HIV, others Aspergillus species, Cryptococcus neoformans, Histoplasma capsulatum, and Coccidioides immitis. Parasitic causes are rare, but include Toxoplasma, Strongyloides decoralis, and even Echinococcus. Then we have the entity aspiration pneumonia. This occurs when gastric or oropharyngeal contents are inhaled, often involving anaerobes like Bacteroides, Fusobacterium, plus gram-negative rods like E. coli or Klebsiella, among others. Now we're going to discuss classification by setting. The first is community-acquired pneumonia. This develops outside the hospital or within 48 hours of admission. Common pathogens include strep pneumonia, which is the commonest, Haemophilus influenzae, Mycoplasma pneumoniae, Legionella pneumophilia. Viruses are also implicated here. Hospital-acquired pneumonia. This develops 48 hours or more after admission or within 14 days of discharge from hospitalization. Pathogens implicated here include Pseudomonas aeruginosa, Klebsiella pneumoniae, methicillin-resistant Staph aureus, Acinetobacter. Ventilator-associated pneumonia. This is a subset of hospital-acquired pneumonia. Occurs 48 hours or more after intubation. Organisms include Pseudomonas, Acinetobacter, and methicillin-resistant Staph aureus, and more. Healthcare-associated pneumonia. This occurs in patients with recent nursing home stay, dialysis, or wound care. Often involves multi-drug resistant gram-negative bacteria. This classification isn't just academic. It directly guides antibiotic choices. Pneumonia can also be classified radiologically. We have lobar pneumonia, bronchopneumonia, and interstitial pneumonia. Lobar pneumonia, an entire lobe is consolidated, classic for infections with Streptococcus pneumoniae. Bronchopneumonia, patchy scattered infiltrates, seen with Staph aureus or Haemophilus influenzae. Interstitial pneumonia, fine reticular or net-like opacities, typical of viruses or atypical bacteria. Pneumonia can also be classified by host factors into immunocompetent and immunocompromised. as in pneumonia in the immunocompromised. Immunocompromised states such as HIV, transplant, malignancy, steroid use, long-term, are all implicated. Organisms include Pneumocystis jirovecii, Aspergillus candida, cytomegalovirus, and a host of others. Always ask a question: is this patient's immune system intact or not? It helps a lot. This slide depicts the radiological classification of pneumonia. Lobar consolidation, as in lobar pneumonia, this is the consolidation in the right middle lobe of the lung. This is the patchy infiltrates, more in the upper lung zone of the right lung, as in bronchopneumonia. And this is the widespread reticular infiltrate, as in interstitial pneumonia. We'll talk about the risk factors now. Who are those that are likely to get pneumonia? Now, we divided this into three: host factors, healthcare associated risks, and exposure risk. For the host factors, we have extremes of ages, less than 5, greater than 65, smoking, alcohol, chronic diseases like COPD, diabetes mellitus, chronic kidney disease, immunosuppressive states, HIV, long-term use of steroids, neurological conditions, stroke, dysphagia, Parkinson's, poor nutrition, and overcrowding and air pollution. Then we have the health-related risk, long-term care facility residents, recent hospitalization and intubation. They've all been implicated. Then exposure-related risk, air conditioning systems, especially in hotels and all, Legionella pneumonia, farm animals, Coxiella bonnetii, as in Q fever, rabbits, Francisella tularensis, as in tularemia, birds, as in Chlamydia psittaci, psittacosis. How do pathogens reach the lungs? There are 4 main routes. 1. Aspiration of oropharyngeal secretions. 2. Inhalation of aerosolized droplets. 3. Colonization of a diseased airway, as in COPD, cystic fibrosis. And 4. Hematogenous spread from a distant infections like endocarditis, skin abscess. Once inside, if the defenses are down, infections will take hold. Let us walk through step by step the pathophysiology of pneumonia, from pathogen entry to the systemic effects that define the illness. First step, pathogen entry. It all begins when the pathogen enters the lower respiratory tract. This happens through inhalation, aspiration, and hematogenous spread from other infection sites. Once inside, the microbes bypass the normal airway defenses, such as mucociliary escalator or immune barriers, setting the stage for infection. There comes alveolar colonization. These pathogens adhere to the alveolar epithelium. They multiply and release toxins. These toxins cause direct epithelial injury, damaging the alveolar lining and triggering inflammation, which is the next stage, inflammatory response. The immune system quickly reacts. Macrophages release inflammatory cytokines like interleukin-1, 8, TNF-alpha. They recruit neutrophil to the site of injury. Neutrophil activity increases capillary permeability, which leads to leaky vessels and exudation of fluid into the alveoli. In the fourth stage, which is the exudation and consolidation, the alveoli is filled with protein-rich exudates, white blood cell, and debris. This consolidation impairs gas exchange, reducing oxygen diffusion and resulting in hypoxia, which is a key clinical feature of pneumonia. If all goes well, we now get to the stage of resolution, which is the fifth stage. Macrophages clear the debris and healing begins. However, If the macrophage fails to clear the debris, the infection will persist and progress to fibrosis, lung abscess, or empyema, as the case may be. Locally, you will find consolidation, pleural effusion, empyema, abscess formation. Systemically, the inflammatory cascade will lead to fever, tachycardia, leukocytosis, hypotension, and sepsis, and in severe cases, multi-organ failure. So in essence, pneumonia progresses through 6 major steps: the pathogen entry, alveolar colonization, inflammatory response, exudation, resolution, or complication. Understanding this cascade helps you to connect the clinical signs of pneumonia to its underlying pathology. Let us quickly summarize the pathophysiology of pneumonia in a simple visual flow. It all begins with pathogen entry. The microorganisms gain access to the lungs through inhalation, aspiration, and spread from the bloodstream. Next comes alveolar colonization. The pathogens adhere to and multiply within the alveoli, damaging the epithelial lining. Then comes the inflammatory response. Macrophages releases cytokines. They draw in neutrophils, which make the capillaries leaky, leading to exudation. As inflammation continues, exudation and consolidation occurs. The alveoli fill with fluids, cell debris, causing impaired gas exchange and resulting in hypoxia. Finally, we reach resolution or complications. If the infection resolves, macrophages clear the debris and healing follows. But if not, it can progress to fibrosis, abscess, empyema, or even sepsis. These changes produce systemic and local effects. Locally, consolidation, pleural effusion, empyema. Systemically, patients may develop fever, tachycardia, sepsis, or even multi-organ failure. Classic lobar pneumonia progresses through 4 stages: congestion, red hepatization, gray hepatization, and resolution. Congestion occurs within the first 24 hours. Lungs are heavy, red, and boggy. They are filled with fluid and bacteria at this stage. In the red hepatization occurs within 1 to 3 days. The alveoli are packed with red blood cells, neutrophils, and fibrin. The lung looks like the liver tissue, red and faint. Hence, it is called red hepatization. Then the gray hepatization within 4 to 6 days. The red blood cells break down, exudate becomes gray and purulent. The stage of resolution within 7 to 10 days. The macrophages clear the debris after enzymatic digestion. So the lungs becomes aerated and the architecture comes back to normal. It is important to state that not all pneumonia follow these processes. Symptoms differ based on the pathogen, either typical or atypical. For typical bacterial pneumonia, it's usually Sunday onset. They have high fever, productive cough with purulent or rusty sputum, pleuritic chest pain, dyspnea, fatigue. In the elderly, watch out for confusion. It may be the only sign. For atypical bacterial pneumonia, such as those from Mycoplasma or Chlamydophila, it's usually gradual onset, low-grade fever. They have dry cough, headache, myalgia, sometimes GI symptoms like nausea or diarrhea. On examination, look out for systemic signs such as fever, tachycardia, hypotension, cyanosis. Respiratory signs include tachypnea and hypoxia, reduced chest expansion on the affected side, dullness to percussion, bronchial breath sound, increased vocal fremitus, crackles, and ergophony. In some cases, they may have pleural rub. Typical red flags include hemoptysis, coughing out of blood, confusion, hypotension, Cyanosis. This means severe disease. Diagnosis starts with history and physical examination. Asks about travel, exposure to birds, AC units, comorbidities, and recent hospitalizations. The initial diagnosis rests on the classic triad of fever, respiratory symptoms, and new chest X-ray infiltrates. Then differentiate between typical versus atypical pneumonia, community versus hospital-acquired pneumonia. This shapes your entire management plan. Key laboratory investigations include full blood count, look for leukocytosis or leukopenia in some cases, C-reactive protein and erythrocyte sedimentation rate. These are markers of inflammation. Procalcitonin helps to distinguish a bacterial from a viral infection. Blood cultures with positive in 10 to 30% of community-acquired pneumonia, also very useful in hospital-acquired pneumonia. Sputum MCS, usually best if collected before antibiotics. It helps to confirm diagnosis and guides therapy. Urinary antigen, rapid test for strep pneumoniae and Legionella. Polymerase chain reaction or serology for atypical bacteria and viruses. EU creatinine, liver function test, HIV test. They assess comorbidities and immune status. Chest X-ray is mandatory in suspected pneumonia. Findings include lobar consolidation with air bronchogram. This is common in pneumonia from strep pneumoniae, typical bacteria, patchy infiltrates, interstitial or reticular pattern in viral or atypical organisms. Cavitations, always think anaerobe staph or Klebsiella. Pleural effusion, abscesses, which reflects complications of pneumonia. If the diagnosis is unclear or complications are suspected, get a CT scan of the chest. It's far more sensitive for abscesses, empyema, or bronchiectasis. These are classic radiographs of lobar consolidation. Dense white opacities with air bronchogram, as you can see in the right middle lobe, and as well as this on the left. This is the diffuse reticular pattern, typical of viral or Mycoplasma pneumoniae. And here you have the patchy bilateral infiltrates, even though more on the right upper lobe, suggestive of bronchopneumonia. This radiograph depicts cavitating pneumonia and the cavity rightfully indicated here. You see the opacity, and within you have the lucencies, making it a cavity. Organisms implicated here include Staph aureus, anaerobes, Klebsiella. The next is CT scan of lobar pneumonia. These are the lobar consolidations. Other investigations include pulse oximetry, arterial blood gases. This helps to detect hypoxemia. Pleural fluid analysis if effusion is present. Bronchoscopy with bronchoalveolar lavage, crucial in immunocompromised or ICU patients. If a patient isn't improving after 72 hours of antibiotic usage, reassess the patient. Could be wrong pathogen, wrong drug, or complication like empyema. Severity assessment. The first we'll discuss is COP65. COP65 is a simple, fast, and life-saving tool that helps determine the severity of pneumonia. C is for confusion, abbreviated mental test of 8 or less. U is for urea, greater than 7 millimoles per liter. R is for respiratory rates, 30 or more per minute. B is for blood pressure, systolic blood pressure less than 90 or diastolic blood pressure 60 or less. And the 65 is age, 65 and above. How do we interpret this scores? A score of 0 to 1 indicates mild pneumonia. Such a patient is managed on outpatient basis. Score of 2 means moderate pneumonia. Such a patient is admitted to the ward. Score of 3 or more indicates severe pneumonia. In this case, you consider ICU management. The higher the score, the higher the mortality. Next is the Pneumonia Severity Index, PSI. It assesses mortality risks and helps to determine the site of care in community-acquired pneumonia. It uses several variables, like the demographics, which includes the age, comorbidities, heart, liver, renal disease, clinical findings, the vital signs, mental status, laboratory findings, as well as finding on image. The PSI classifies patients into 5 risk classes, 1 to 5. This table highlights the risk categories of the Pneumonia Severity Index from class 1 to 5. Risk class 1 and 2 for outpatient care, risk class 3 for short hospital observation or a brief admission, class 4 for an inpatient care, class 5 for an inpatient care, and often in the intensive care unit. Differential diagnosis of pneumonia. It's important to note that not every infiltrate is pneumonia. Therefore, you consider differentials like acute bronchitis. These persons have cough, but usually they have a clear chest X-ray. And acute bronchitis is often viral. Next is pulmonary edema. Pulmonary edema, they have bilateral opacities, what we call the bat wing opacities. They may have a cardiac history and an S3 gallop. Lung abscess. Lung abscess is a cavity with an air fluid level. Tuberculosis, chronic cough, night sweat, and may have upper lobe lesions. Heart failure is another differential. This presents with autopnea, paroxysmal nocturnal dyspnea. They may have cardiomegaly and features of heart failure on chest X-ray. Lung cancer, weight loss, hemoptysis. There may be a mass lesion on chest X-ray. Pulmonary embolism. This presents with sudden dyspnea, pleuritic chest pain. They may have normal or an abnormal chest X-ray. If untreated or severe, pneumonia can lead to the following complications: parapneumonic effusion, empyema, lung abscess, necrotizing pneumonia, sepsis, septic shock, acute respiratory distress syndrome, respiratory failure, even pericarditis, myocarditis, or brain abscess. Early recognition and treatment helps to prevent these complications. Management of pneumonia. We'll start with the general principle. Must ensure early diagnosis and severity assessment using either the COP-65 or the Pneumonia Severity Index. Ensure oxygen therapy to maintain oxygen saturation above 94%. Ensure fluid therapy if the patient is dehydrated or in shock. Prompt empiric antibiotics therapy based on setting and treat complications aggressively. Empiric antibiotics therapy. Before culture results are out, patient has to be started on empiric therapy. For community-acquired pneumonia, this depends on severity. For mild cases of pneumonia, which are managed on outpatient basis, if there is no comorbidity, regimen includes amoxicillin or doxycycline or macrolide, such as azithromycin or clarithromycin. For mild cases with comorbidities like COPD, heart failure, CKD, we give beta-lactam like amoxicillin clavulanate plus macrolide or doxycycline. Alternatively, patients can be placed on monotherapy with respiratory fluoroquinolone like levofloxacin or moxifloxacin. For moderate pneumonia, patients are managed as inpatients. We use beta-lactam antibiotics like amoxicillin clavulanate or ceftriaxone or cefotaxime plus a macrolide. Alternatively, monotherapy with respiratory fluoroquinolones with levofloxacin or moxifloxacin can be used. This time, parenteral medications are used. For severe cases of pneumonia managed in the ICU, the beta-lactam antibiotics like ceftriaxone, cefotaxime, or ampicillin sulbactam, plus a macrolide or a fluoroquinolone are used. If the patient has a risk for Pseudomonas infection, an anti-Pseudomonas is added like piperacillin, tazobactam, cefepime, or meropenem. If there is a risk for methicillin-resistant Staph aureus, vancomycin or linezolid may be added. For hospital-acquired pneumonia or ventilator-associated pneumonia, we assume that the pathogens may be multi-drug resistant. First-line regimen include piperacillin, tazobactam, or cefixime, or levofloxacin, or meropenem. If there is a risk of methicillin-resistant Staph aureus, you add vancomycin or linezolid. If there is a high multi-drug resistant risk, e.g. in ventilator-associated pneumonia, you may need to add amikacin or colistin, but ensure you follow local guidelines. For aspiration pneumonia, ampicillin sulbactam or clindamycin plus ceftriaxone is a good coverage. Metronidazole is also important if anaerobic coverage is needed. For pneumonia in the immunocompromised, the broad base is piperacillin tazobactam or cefixime or meropenem. You can add vancomycin or linezolid if methicillin-resistant Staph aureus is suspected. You can add voriconazole or amphotericin for fungal infection. You can add trimethoprim sulfamethoxazole if pneumocystis jirovecii is suspected. It is important to state that you tailor antibiotics after culture results are out. Other specifics are antiviral therapy for viral pneumonia, like influenza, antifungal therapy for histoplasma, aspergillus, candida, and others. For pneumocystis jirovecii infection, you may think trimethoprim sulfamethoxazole. How long do you treat pneumonia? For uncomplicated community-acquired pneumonia, 5 to 7 days. For hospital-acquired pneumonia or ventilator-associated pneumonia, 7 to 10 days. For aspiration pneumonia, 10 to 14. And for pneumonia in immunocompromised patients, 10 to 21 days. Don't forget supportive and adjunctive care, such as oxygen therapy, IV fluids for dehydration or shock, electrolyte corrections, antipyretic and analgesia, nutritional support, choice physiotherapy, and venous thromboembolism prophylaxis, especially in hospitalized patients, corticosteroid use in refractory septic shock or in severe pneumonia, and always manage comorbidities like controlling blood sugar and diabetes and others. For complications of pneumonia, like empyema, basically management is chest tube drainage and antibiotics. For lung abscess, prolonged antibiotic use, plus or minus drainage. For necrotizing pneumonia, broad-spectrum IV antibiotics, with or without surgery. For acute respiratory distress syndrome, mechanical ventilation and ICU support is very important. And for sepsis or septic shock, you follow the sepsis bundle, basically, in terms of management. After starting treatment, reassess patients at 48 to 72 hours. If the patient is improving, then you continue management. If it is not improving, you either think, could this be a wrong diagnosis or a resistant pathogen, or is there complication? Repeat chest X-ray at 6 to 8 weeks. If the patient is above 50 years, the patient is a smoker, or symptom persists, this is to help you to rule out other pathologies like lung cancer. Prevention is a powerful tool, and this could be through vaccination, lifestyle measures, or hospital or public health measures. For vaccination, there are pneumococcal vaccines for high-risk group, annual influenza vaccines also. These prevent viral pneumonia and secondary bacterial infections. High-risk group include the elderly and immunocompromised, like HIV, those with ASPLEN, and also those with CSF leak are parts of the group. Then lifestyle measures like limiting alcohol, stopping smoking, maintaining good nutrition, and practice oral hygiene. This helps to reduce aspiration risk. The infection control such as hand washing, ventilator bundles in ICU, and isolation of contagious cases in some cases, especially in cases like flu, are also important public health measures. Prognosis. Most patients recover fully with timely treatment. However, poor prognostic factors include advanced age, comorbidities like COPD, CKD malignancy, multi-lobar involvement, severe disease, delayed antibiotics, and immunosuppression. Mortality varies by setting. For outpatient community-acquired pneumonia, mortality is less than 5%. These are mild cases. For moderate and severe cases, the mortality increases. For example, for community-acquired pneumonia in ICU, it goes up to 30%. For hospital-acquired pneumonia and ventilator-associated pneumonia, mortality gets up to 30 to 50%, especially those with multi-drug resistant organisms. Let's test our knowledge with this clinical case challenge. A 65-year-old man with hypertension presents with 3 days history of fever, productive cough, and dyspnea. Respiratory rate is 28 cycles per minute. Oxygen saturation is 88% on room air. Crackles in the right lower lobe on examination. And chest X-ray showed right lobar consolidation. The questions include: what's the diagnosis and severity? 2. What empiric antibiotics would you start in this patient? Drop your answers in the comments. Clinical case challenge 2. A 40-year-old woman intubated post-surgery develops fever and purulent tracheal secretions after 5 days. The questions are: what type of pneumonia is this? What empiric therapy is indicated? Kindly drop your answers in the comments. Now let's wrap up this session. Pneumonia is an infection of the lung parenchyma causing alveolar inflammation and consolidation. Classification is by setting, by etiology, or by radiologic pattern. Diagnosis is based on symptoms, signs, and imaging. Assess severity using COP65 and the Pneumonia Severity Index. Prompt empiric antibiotics with supportive care saves lives. Prevention through vaccination and infection control is essential. Master this and you will manage pneumonia like a pro. Thank you for staying with us in this deep dive into pneumonia. If you found this helpful, please like, subscribe, and share with your colleagues. Also hit the notification bell so that you never miss an episode of clinmedcompass series. Until next time, stay curious, stay compassionate, and keep learning. This is clinmedcompass, your path to medical excellence.